Hi, I'm Anthony Clough from North Eastern Weight Loss Surgery, one of two surgeons performing weight loss surgery at this clinic. The other surgeon's Patrick Moore, our clinical dietitian is Meryl Bone, and our practice manager is Christine Malone. I want to talk about gastric bypass first because out of the three operations that I'll focus on, this is the operation that's been around for the longest, in fact about 50 years or so. And the other thing about gastric bypass surgery, it really does demonstrate many of the main technical issues that explain how the weight loss occurs and what we're actually doing to the body or what we can do to the body to enforce weight loss. So the first thing we do in gastric bypass surgery is create a small pouch. We do this at the top of the stomach, a pouch about the size of an egg, and we make it with stapling devices. So when you eat, the food goes into the small pouch and you cannot fit much food in that pouch, so you feel full quite quickly. The pouch is then connected directly to the small bowel, bypassing the main bulk of the stomach and the duodenum, so food and fluid just goes straight out of the pouch into the intestines, and further on down the intestine is connected back to all the bile and digestive enzymes which are coming from the duodenum. The fact that all the food and fluid comes so quickly through the system causes the body to pause, causes hormones to be released that act on the brain and on the body to say, hey, slow down, you're eating too quickly, we don't need so much food. So the other thing that may be occurring in gastric bypass surgery is a little bit of malabsorption of calories. There's the food going through what we call the ruling, which is the main bit of bowel coming up to the gastric pouch. Doesn't have any digestive enzymes to help with absorption, and there's a little bit of bowel further down which doesn't see any food. So there's those three, I guess, mechanisms which cause weight: restriction of food, hormonal effects reducing our appetite, and a little bit of malabsorption of calories. This is the sleeve gastrectomy. Sleeve gastrectomy is conceptually simpler than the gastric bypass and was originally performed on very, very heavy patients in whom gastric bypass or biliopancreatic diversion may have been too technically difficult and dangerous. Sleeve gastrectomy was originally conceived as a first part of a two-component operation. The patient would have the sleeve of the stomach, lose some weight, and then when the weight was more favourable, when it was technically easier to do, they'd go back and do the second stage, which was a biliopancreatic diversion. But in the last 5 or 6 years, it's been apparent that sleeve gastrectomy in itself is a fantastic weight loss operation, and most people may not need the second component. So here what we do is we create a long narrow tube out of the lesser curved side of the stomach, and we actually throw away the rest of the stomach, which is approximately 2/3 to 3/4 of the stomach. So we're left with a long narrow tube of stomach. It's clearly irreversible, as we cannot put the stomach that we've resected back. And it is really the only operation that I'll talk about which is completely irreversible. So this operation works by restriction of food volume, because the volume within the long narrow sleeve is only 100 to 200 mils. So you feel full quickly because of filling up of that stomach pouch. The second way that this operation is thought to work is by resecting some cells on the body which secrete ghrelin. Ghrelin is an appetite stimulant, and by resecting those cells we should reduce appetite. And often when you talk to patients who've had sleeve gastrectomies in the past, they will tell you that they don't even feel like food, and sometimes they have to literally remind themselves to eat to get the nutrition down. The problem with the sleeve gastrectomy, apart from it being irreversible, is it's really only been around in this form for 5 or 6 years. With gastric bypass, we have up to 50 years of study. Some of the better studies around have shown us figures around 15 or 20 years down the track. And it's quite clear that gastric bypass is a very effective and sustainable operation in the long term. With gastrectomy, the question mark remains: what are the effects on the body of removing most of the stomach, particularly in someone who's relatively young? Is the stomach that remains, is it going to enlarge, and therefore are people going to regain weight? And there is a little bit of evidence that after 3 or 4 years people do regain a little bit of weight with the sleeve gastrectomy, but that's probably true of any of these operations. The other thing about the sleeve gastrectomy, if you're prone to reflux, the sleeve can actually exacerbate reflux. It's unusual that a patient would get so much reflux that they would need to have some sort of surgery to control it. Normally medications are enough. Gastric bypass surgery, on the other hand, will essentially eliminate gastroesophageal reflux in most patients, and that's because you're disconnecting the esophagus from the bulk of the stomach where the acid is produced. So gastric banding is the most familiar to most people, where we put a silicone balloon, adjustable silicone balloon, around the top of the stomach to create a small virtual pouch above it where the food and fluid can enter. The band is then connected by some tubing to an access port under the skin, which can be accessed by a surgeon to make the band tighter or looser, as the case may be, to increase the amount of restriction on your food volumes. The band certainly restricts your food volumes because of its mechanical effect on the top of the stomach, but it's also thought to play a role in appetite suppression, either by pressing on the nerves of the stomach itself, or perhaps even the vagus nerve behind the stomach, which is the main digestive nerve. So, in the best case scenario, when the band's adjusted right for the right person, it restricts your food volumes, it makes you less hungry in between meals, and should make you more satisfied with a small amount of food at each meal time. It certainly won't prevent liquids going down, so high calorie liquids such as fruit juices, cordial, milkshakes, all that sort of thing, alcohol, is not really going to change much with gastric banding. The bypass, you could argue that if you drink a lot of high calorie liquids, high sugar liquids, you'll get dumping syndrome. So dumping syndrome is because these high sugar, high calorie liquids get into the bowels too quickly, or more quickly than the body's used to, and the body has a reaction against it. Nausea, palpitation, sweatiness, it's an awful feeling. And people who experience dumping syndrome will very quickly learn not to have those kind of fluids or foods that set it off. So perhaps bypass has an added advantage. If you are someone who eats a lot of chocolate or drinks a lot of sugary drinks, you may be less inclined to do that with the bypass. Now, one of the problems that we found with the band is that the weight loss results can be quite variable. We talk in terms of excess weight, which is the amount of weight that you have above a BMI of 25. Well, at least that's one definition. So if you're 120 kilos and your ideal weight is 70, then your excess weight is 50 kilos. And with the band, your average excess weight loss is going to be somewhere between 50 and 55%, sometimes up to 60%. Usually with the bypass and the sleeve, certainly in the short term and probably the medium term, we're seeing slightly more weight loss. So with the bypass, it may be 60 to 80% on average. The sleeve is still a bit of an unknown in the long term, but we're seeing 60, 70, sometimes 80% in 1 to 2 years with the sleeve. The other issue of importance is how reliable the weight loss is going to be. What are your chances of succeeding with significant weight loss with any of these operations? And this is one of the issues with the gastric band. The chance of you getting to 50% of excess weight loss is itself about 50%. So half the people who have the band won't even get to 50% excess weight loss, although there's another half who are doing even better. With the sleeve, we're seeing probably more like 85% getting to 50% excess weight loss after 3 years. So in a sense, it and the gastric bypass are much more reliable in terms of getting you to that figure that you want to be, as well as probably producing a little bit more weight loss overall. So why has the sleeve gastrectomy become such a popular operation in Australia? First of all, the weight loss outcomes tend to be more reliable than gastric banding. Secondly, it's upfront, safer and simpler than a gastric bypass. You cannot get a marginal ulcer with a sleeve gastrectomy, whereas in gastric bypass you can, and that ulcer can cause bleeding and pain. You cannot get good small bowel obstruction with sleeve gastrectomy, whereas in gastric bypass we know you can. People tend to tolerate foods of all different kinds a little bit better with the sleeve compared to to banding, and certainly the appetite suppression seems to be quite significant with the sleeve. If down the track you regain weight, or you have a problem like intractable reflux, it's certainly possible and perhaps not even too difficult to convert the sleeve gastrectomy to a gastric bypass. The top pouch, which you would make in a gastric bypass, is already half made once you've done the sleeve. I think it's important to have an understanding of the potential complications that can occur with any of these operations, and I'll start with gastric bypass surgery. The thing that unfortunately puts a lot of people off gastric bypass surgery, even though it's such a fantastic operation, is the major complication, including death rate, is higher than the other operation. And the chance of you dying from a gastric bypass operation is probably something around 1 in 200, or maybe a little bit less. That's about the same as a total hip replacement. People die from this operation because of leaks that can occur either from the joint in the bowel or above the joint in the bowel, and sometimes from medical problems such as pulmonary embolus, that is clots that occur in the legs and go to the lungs, or maybe even heart attacks. Down the track you can get ulcers around the joint, you can get small bowel obstructions, but by and large, once you've done the bypass, it's unlikely that you're going to need too many more procedures. Some people get a bit tight at the joint and need a bit of a stretch, and occasionally there's something called a gastric fistula, whereby the two stomachs join up again and your weight loss is not as good. But compared to, say, gastric banding surgery, where reoperation rates can be quite high after 3 or 4 years, things such as readjusting a slip band, readjusting a port that's not working properly, removing a band that's eroded. Once you have gastric bypass done, by and large things are set and forget. So the sleeve gastrectomy is probably midway between banding and bypass in terms of complication rates. Your risk of death with a sleeve gastrectomy is something around 1 in 750. Other complications that can occur with a sleeve include gastric leakage, which normally occurs from the top of the staple line, and this happens in 1 to 2% of cases. Bleeding can occur, usually that just requires a transfusion to control, occasionally reoperation. Rarely you can get narrowings further down the sleeve, which can cause obstruction or even twisting of the sleeve. In the worst case scenario, if you have a problem such as this that cannot be resolved, one can convert it to gastric bypass. If you're prone to reflux, the sleeve gastrectomy can worsen your reflux. So what about gastric banding surgery? I think one of the reasons gastric banding has been so popular in this country is that the upfront complication rates are quite low. It's a completely reversible operation which does not involve cutting or stapling the stomach or mucking around with a small bowel. The death rate in gastric banding surgery on average is about 1 in 2,000, which is quite favourable compared to, say, gastric bypass. It is possible to damage the stomach or esophagus when putting the band around, but it's very uncommon. If that happens, it can be quite a severe problem. The band can slip out of position any time from the first few months to several years down the track, and that occurs in about 2 to 5% of cases. That is, erode into the stomach, whereby part or all of the band becomes inside the stomach instead of being outside the stomach, and that occurs in about 1% of cases. If you have a gastric erosion, you really need your band removed. The esophagus above the band and the gastric pouch above the band can sometimes be under prolonged pressure over time, and they can stretch and even burn out with time. This happens quite rarely. A number of issues can occur with your access port. The port can flip, become infected, migrate or leak, and a small percentage, maybe 5% of people, will need a reoperation on the port to fix a minor problem. I think it's worth mentioning with gastric banding surgery, it really is just a tool. You need to be prepared to work hard with the band. You need to be prepared to eat your food slowly, choose appropriate foods that aren't going to make you, that aren't going to get stuck in the band or make you vomit. You need to chew your food carefully, and you need to be patient. So that concludes my video on the different weight loss surgery options.